I'd like to talk to you about lab-based research as opposed to clinical research in the context of orthopedics and why you might want to think about research even though what you signed up for was to become a clinical doctor. Hello, my name's David Findlay. I'd like to talk to you about lab-based research as distinct from clinical research in the context of orthopedics, and why you might want to think about research, even though what you've signed up for is to become a clinical doctor. Hello, this is David Findlay speaking. I'd like to talk to you about lab-based orthopedic research as opposed to clinical research. And we're talking about research in an orthopedic setting and why you might want to think about research when you feel like what you've signed up for is to learn about clinical medicine. Hello, this is David Findlay speaking. I'd like to talk to you about lab-based research as distinct from clinical research in the context of orthopedics and why you might want to think about research even though what you've signed up for is to become a clinical doctor. So the questions one might pose are, why do research at all? Why would a medically trained person do research? What are the knowledge gaps in orthopaedics? And what research do we, as in orthopaedics and trauma at the University of Adelaide and within Callan, do? There are really important reasons why a medically trained person would do research. It is essential that you as a doctor understand about evidence base so that you don't just accept everything that comes along, so that you can drill down and demand a good, strong evidence base before you accept any new procedure or medication for that matter. It's also important to have a pool of medically trained people who create an evidence base, who find that evidence and put it together in a compelling way. That's how medicine changes in a reliable way rather than lurching from unproven thing to unproven thing. And it is really important for you to develop the skills to be able to evaluate new developments. And I guess that's comes back to understanding evidence base. Here is an example of where understanding evidence base and demanding evidence for a procedure might have saved a lot of money and a lot of unnecessary procedures being performed on people. So the diagram shows vertebral augmentation, several ways of trying to support a fractured vertebral body, particularly after an osteoporotic or fragility fracture. And you can see various methods of expanding back that vertebral body and adding cement into that vertebral body to keep it raised. It all looks okay, but from a hard-nosed evidence-based point of view, this procedure did not stand up. So despite the absence of clear evidence for efficacy, and that's what was found when the evidence was sought, and potential safety concerns, and there were several, an estimated almost 82,000 patients underwent vertebroplasty, and an even larger number of patients underwent kyphoplasty in the United States between 2006 and 2014. The costs were quite considerable, as you can see here. But the meta-analysis conclusions were clear. Vertebroplasty provides no clinically significant benefit in terms of pain control over placebo or sham procedures based on 5 randomized placebo-controlled trials evidence. So, and for kyphoplasty, there was weak evidence of benefit in 1 clinical trial. What you do as a medically qualified person must align with the evidence, and I would encourage you to be always searching for the evidence and part of the group of people that puts the evidence together. Second example is of bone morphogenetic proteins. The history of the discovery of bone morphogenetic proteins, or BMPs, is a really nice story of discovery. And these are proteins that reside in bone, although in a large number of other tissues as well, it now turns out, that are responsible for morphogenesis of tissues in development, and also was shown to have very good capability to enhance bone formation during fracture repair. For BMPs, there were animal studies and then clinical trials with BMPs to examine their efficacy for bone healing and fracture repair. And they were actually approved for enhancement of fracture repair, particularly in recalcitrant fractures. However, here is a recent systematic review looking at the results of all of that and examining now the evidence, the real world, the post-marketing evidence for the efficacy of BMPs in the treatment of bone fractures and non-unions resulting from fracture and for osteonecrosis. And the results are as follows. So the conclusion of this systematic review is shown here, and at best what the authors could come up with was controversial clinical evidence to support the use of BMPs in the treatment of fractures. The problem was that some reports were of low quality. There were some positive findings, but the overall literature presented mixed results in terms of both efficacy and, importantly, adverse events. And the difficulty in drawing clear conclusions on BMPs were due to the heterogeneity of those published studies, and it has to be said with some industry vested interests inserted in there as well. And so given that BMPs are very expensive, they tend not to be used very much now, despite offering a lot of promise. And that's their status in orthopaedics, particularly in Australia, where the cost really can't be supported. A bit of a PS on BMPs. The biology remains fascinating and is helping researchers understand numerous biological activities. For example, this disease shown here, this really quite awful disease called fibrodysplasia ossificans progressiva, or FOP, where the soft tissues start to turn into bone to the extent where eventually people can't breathe. And it's an understanding of the fact that BMPs and their receptors are at the basis of this disease that is leading to new approaches to therapy for these people. And there's a real hope that based on animal experiments that this disease can be treatable in the near future. So there are other very good reasons why a medically trained person might get involved in research. It's very important, particularly in medical research, that there is a strong link between those at the coalface seeing patients and those in the lab doing the research, so that the results from the lab have medical relevance and that the right questions can be asked from a medical point of view. It's also important to know which of those many questions that arise from seeing difficult diseases is actually possible to ask. And of course, the range of those is increasing all the time with new technical capabilities arising. It's also a very good thing to get involved in research to develop skills in analysis and understanding and performance of statistics. And so many times when medically trained people have got involved in research, they've been able to break new ground and create new knowledge, which has been of fundamental importance. And I don't have to give you a list of those, but you might think about antibiotics, you might think about vaccines, you might think about a whole lot of procedures that have changed the face of medicine. Some other very good and quite pragmatic reasons why you might want to be involved in research are to become a clinician academic, and some of you will want to go down that path. Some of you will want to become teachers in all kinds of ways, but to become an informed, up-to-date teacher, you need to be on the cutting edge of knowledge, and that's where being involved with research puts you. And you might want to become a thought leader, for which you need to be a composite of many of the things that we've talked about on the last few slides. But really, you need to be plugged into current knowledge, and thought leaders, because of their involvement in research, will go to the conferences, will have an international network of people that they talk to, and will be up to date in current knowledge. And I think that's a pretty neat place to be, rather than one of the followers, one of the people leading new thinking. And I think that involvement in research and learning to think like a researcher can make your job as a doctor much more interesting. Just an example is, why is there such variability of response in different people to the same treatment? So coming now to why we do research in our group, what are the knowledge gaps in orthopaedics? And I guess the subtext there is, surely we know enough already. Don't we know how to treat all orthopaedic problems? Don't we know how to treat them in the best way possible? Obviously, these are rhetorical questions, and I think that it is unacceptable that we have no knowledge really of diseases like osteoarthritis that afflict so many people. We need to keep on with research. So some of the important knowledge gaps in orthopaedics are listed here. First one is an epidemiological question of who gets what disease and why. And so diseases such as osteoporosis, we need much better answers about who gets these, how we can determine which people need to be treated, will benefit from treatment, and so on. Bone infection is emerging as a really blockbuster, important disease state that to treat. For example, if you get a bone infection as part of your total joint replacement, that will plunge you into incredible misery as a patient. And we need much better understanding about why people get infected and what to do about it. Spine pathologies of all sorts remain quite challenging, and some bone tumours are frankly untreatable right now. So we need much better answers for those, particularly rare bone tumours, some of the sarcomas, giant cell tumours, and a range of other rare tumours. So there is plenty to do and a lot more to know, and we need research. Some of the research that our department has become involved in over time, and much of it is still current, come under the general heading of joint replacement research. So what are the modes of failure of joint replacements? And we've learned a lot about how implant components wear and how the tiny wear particles that are generated when the bearing surfaces wear produce periprosthetic osteolysis, the loss of bone around the implants. We've learned about dislocation and some of the ways that might be countered in the design of the implant components. We are learning a lot about infection, and that's a large current project going on in our group, headed up by Professor Gerald Atkins. We have learned about the design of implants and about the loads on them and about how they sometimes break. And we've learned about how the bone that the implants are in also fracturing, and periprosthetic fractures are also very unpleasant side effect of joint replacements, and we need to know more about the biomechanics of that situation, the biology of it, how to repair it satisfactorily, and so on. So these are live topics of research from which we're learning a lot in our research. Some of that research is shown here. You can see in this CT some of the lost bone around the acetabular component of a total hip replacement. You can see the almost complete wear of the polyethylene liner, so that now the head of the femoral component of the total hip replacement is sitting strangely in the acetabular component. So we've developed CT analysis software to quantitate that bone loss, and that's enabled us to investigate risk factors for that loss of bone. And we've gone on in the lab to investigate the bioactivity of polyethylene, both conventional and highly cross-linked polyethylene, and metal particles, to understand how that wear process plays out biologically within the bone. Here's another example of our research where the clinic meets the lab. So here is shown a fracture of the tibial plateau, and we've been able to investigate better ways to treat that, and used a whole lot of new technology to investigate the outcomes of that fracture repair in terms of function and activity of the patient post rehab. So this is really getting us into a whole new area of orthopaedic research of crucial importance, not just examining how the X-ray shows that the fracture is healed, but how the patient is doing afterwards in concrete functional ways that matter to the patient. Our research in the lab has focused for a long time on what is happening to the cells in the bone. It is, after all, these cells that drive everything that bone does. And of particular importance are the cells trapped within the mineral component of the bone called osteocytes. And you can see those cells stained green here. quite dense within the bone and with very interesting characteristics such as these long extensions that join them to each other and allow them to communicate with the vascular elements also shown on the picture. Osteocytes produce a protein product called sclerostin. Sclerostin was discovered because mutations of sclerostin, which render it non-functional, result in this disease here, sclerosiosis, massive bone overgrowth in the skeleton, and shown here, causing all kinds of problems with the skull. And this discovery led to the notion that neutralization of sclerostin, this negative regulator of bone formation, might be able to be exploited to produce more bone in people who need more bone, people with severe osteoporosis and so on. And that has indeed been the case, and there is now an antibody therapy available for use to build more bone in people. And we have put a lot of work into understanding this molecule sclerostin, the biology behind it, how it works, what it does on a cell basis and so on. So osteocytes are embedded in bone and they make sclerostin. They are almost the sole producers of sclerostin in the body, and sclerostin, as noted earlier, is a negative regulator of bone formation and is able to negatively regulate the activity of osteoblasts, which are the producers of new bone. Well, we showed also that sclerostin increases bone removal or resorption by osteoclasts. And we showed that it does so by increasing the production of a molecule called rank ligand, which is central to osteoclast activity in the body. And this was a very important piece of work in understanding the therapeutic application of sclerostin neutralization. We've also become very interested in osteoarthritis because, as I said earlier, osteoarthritis is an almost totally not understood disease, and most of the joint replacements that occur in orthopaedics occur because of osteoarthritis, this disease of joints which manifests by loss of articular cartilage as shown here. However, the bone under the cartilage, the subchondral bone, is also very important in the development of arthritis, and we've done a lot of work to investigate the structural changes of that bone and how they interplay with the degradation of the cartilage. And we've investigated the biology, the expression of genes, the expression of key molecules in both the bone and the cartilage, and starting to get a better picture of the events happening, at least in knee arthritis, and we plan to extend this to other joints in the future. We've been very interested in the work of a collaborator of ours at Johns Hopkins University in the United States, Professor Zhu Kao, who's shown a key role for a molecule called TGF-beta in the development of osteoarthritis. And so an experiment that he performed was to specifically overexpress active TGF-beta in the bone under the cartilage in mice. And what he showed was that the whole scenario of arthritis was exacerbated in these mice. So it looked as though, from his work, as though TGF-beta may be a key player in the development of arthritis. Professor Kao went one important step beyond this and showed that the neutralization of TGF-beta by using TGF-beta antibodies in these mice preserved the articular cartilage, and you can see that in the boxed area here. He found a dose, happened to be 5 milligrams per kilogram of neutralizing TGF-beta antibody that totally preserved the joint of mice that would normally get arthritis. Again, showing at least in this animal species the importance of TGF-beta in the development of this condition. What Professor Cow's work did not indicate was whether TGF-beta might be involved in human arthritis, and so the experiment we've done is to measure TGF-beta, active TGF-beta, compared to inactive sequestered TGF-beta in the bone collected during knee replacement surgery from osteoarthritis sufferers. And what we see is that in areas of that bone, underneath zones where the cartilage has been degraded away, the concentration of active TGF-beta is much greater than where the cartilage is relatively preserved. So we believe from this that TGF-beta may in fact play a role in humans, and if we can substantiate this, this might open the way for clinical trials for TGF-beta inactivation in this condition.